The Bethany has resorted to puffs.
Wow.
Wow.
You guys are the first class.
Now, what does that mean?
We normally do labs
She's
after.
now corrupted. Next she's going to start drinking.
Oh, you didn't drink coffee
It's an
before?
Irish coffee.
Slippery slope. Cocaine.
Wait.
What's
So,
wrong with a good Irish coffee?
so Bethany, what did you do before? What did you do before? Nothing? Water? I got water.
Good for you.
I'm telling you guys, water's better.
Two cold glasses of water in the morning,
But-
two at night.
The problem is that it has the opposite effect. So it doesn't help with volume at all. It decreases your volume, so you get more dehydrated
Thanks for trying to say
because it's a diuretic. What's that? Water and coffee? Then you're just peeing a lot.
a bunch of caffeine in water.
That's the same as coffee. Right?
Doesn't taste as good.
All right. VTAC. Now we get into the cool stuff. So this is 3 or more PVCs occur in a row with a rate more than 100. If it's less than 100, how do you recognize that? Accelerated IVR, right? More than 100, it's VTAC. You got non-sustained VTAC, in a short run, less than 30 seconds. Sustained VTAC is more than 30 seconds. Well, they might have a sustained VTAC for 45 seconds and then spontaneously fix, but they're going to have some serious symptoms in the meantime. So how do you recognize it? Wide and fast, right? Wide and fast, VTAC. There is monomorphic VTAC and then polymorphic VTAC. Monomorphic is all, the amplitude is relatively all the same. It all looks pretty similar, right? This is the same there, but it's going so fast here that you don't even really see any T waves. Monomorphic is usually pretty fast, so 100 to 250, essentially regular. You don't see any P waves, even if there might be P waves buried somewhere. QRS is wide. Are you perfusing with VTAC? What do you think?
Not very well.
Depends on how fast it is. If you got VTAC at 110, you think you're perfusing? Yeah, you've got filling. It's not optimal because there's no atrial kick, right? But you still are doing all right. You got VTAC at 200. Are you perfusing? No. Polymorphic VTAC. What's that starting to look like? Torsades. It's not quite torsades yet. It's certainly starting to look like it. Polymorphic is even faster. So it can get up to 300. It's usually over 200. Maybe regular or irregular. It just looks funky. There's no P waves, no PR interval. QRS is wide.
How do we distinguish that from torsades?
We'll talk about it. That's coming. That's all saying the same stuff. So the types of polymorphic VTAC, there is normal QT and long QT syndromes. And long QT can either be acquired, meaning medications, or congenital. They're just born with a prolonged QT. So polymorphic in the presence of a long QT is torsades. All right, VTAC with a long QT is torsades. So what's a common overdose that can cause torsades? That's a good guess. I think if I was going to guess and had no idea, ditch would be a good guess. Oh, a TCA overdose. Tricyclic?
They start out wide and then turn into the
Yeah, they start out wide, and if they're bad and continued, they can turn into torsades wide. TCA causes what? Prolonged QT. So even in normal concentration TCA patients, they're going to have a little bit prolonged QT. So if they start taking too much and it turns into a wide VTAC type picture, it's a prolonged QT and it's going to become torsades pretty quick. What do you give for torsades? Magnesium. Good.
The doctor,
Yeah.
what was that medication you just said?
TCA overdose, tricyclic antidepressant.
Is that kind of like sulfa drugs?
Is
Is that
a
broad
typical
thing of
tricyclic.
different
What am I trying to think of? I don't. Quinidine is a TCA. There's more common ones. I can't even think of them right now. I see that no, lithium's not a TCA. It's a different kind of, or it's for bipolar. But I can't think of the more common TCAs right now. When I see them, I know that it's a TCA, but I can't think of the names.
The ones that we see are amitriptyline.
All right, there's probably your most common is amitriptyline.
Yeah.
You don't see them a whole lot anymore. They used to be very common antidepressants, but the other ones are so much better that TCAs are not on board as much as they
So
used
that's
to.
the only thing that causes torsades, then?
What's that?
Is that the only thing that causes that?
No.
Torsades?
No, I mean, if the patient has congenital prolonged QT, and for whatever reason they go into VTAC, then that'll turn into torsades. So it's just VTAC with a prolonged QT. Anything that creates a prolonged QT can turn into torsades if in the right situation. So polymorphic VTAC with a normal QT is just polymorphic VTAC, right?
So the QT intervals of repolarization. Why is a long repolarization time in which you the VTAC?
It's not necessarily, well, it's not solely repolarization. What's that? What's the segment of QT? Where is it? The beginning of depolarization. So whatever the beginning of that QRS is, to what?
No, it's an interval, it's all of T. So through repolarization.
Uh-huh. You said apex of the T wave?
I was trying to think about absolute resculpting pressure.
Oh, okay. It's usually the end of the T wave. So Q wave to the end of the T wave is QT interval.
So how does that work with VTAC?
If you have it won't necessarily put you into VTAC. It's just that if a patient goes into VTAC with a prolonged QT, it can turn into torsades.
Oh, so how prolonged doesn't equal torsades?
No. A patient can have a normal sinus rhythm and be taking amitriptyline and have a prolonged QT and never have any problems with it.
So like I said,
One doesn't equal the other. It's just that in order for VTAC, or polymorphic VTAC, to turn into torsades, it does that when there's a prolonged QT. It doesn't mean that a prolonged QT will always turn into this or that. Some people normally have a prolonged QT. It's just congenital for them. Is everybody clear on that? One does not equal the other.
with polymorphic VTAC, how do we distinguish what the T wave is?
That is a good question. Can you tell where that T wave is? Can you tell where the isoelectric line is?
In the middle.
I think here.
Right.
Is it right there? It's in black.
The QT in this situation is basically the beginning of the complex to the end of the complex.
The whole strip.
It's the whole strip. That's a really prolonged QT. So long QT syndromes. What's that?
So we just measured complex, and if it's prolonged, or prolonged for a QT, and that's torsades.
No, torsades is going to look a certain way. This is polymorphic VT. This isn't torsades.
If we measure that, and it does have a long.
In general, you're not going to look at a polymorphic VT and then be like, oh, this might be torsades. I'm going to measure out the QT. Torsades has a very specific looking pattern. And when you see it, you know it. Just like VFib. You see VFib, you're not measuring anything on it. You just, the patient's in VFib, right? Torsades is a similar thing where it just looks a certain way. Now, some people might look at a normal polymorphic VTAC and say, it kind of looks like torsades, because torsades does have this high amplitude, low amplitude, but it looks much different than that, meaning that you've got a lot crazier looking complexes, you've got more exaggerated complexes. It's
Rhythm cycle.
yeah, it's completely messed up. I think
I'm gonna give a picture going.
I think we have a picture of torsades
You shot them
later. What's that?
You shot them both.
You can defibrillate them, yeah.
Oh shit! So you
I didn't go through this last night.
Ooh, I know that's not mine.
You can defibrillate a torsades, but it's not going to help.
Oh.
Now a normal polymorphic VT, you can shock and that can help, but a torsades, that is not going to be fixed until magnesium's on board. Yeah, because you're not fixing the underlying cause. So long QT syndrome. Abnormality of the heart's electrical system. The mechanical function of the heart is entirely normal, meaning the contraction, the muscles are fine. It's an electrical defect. Prolongs the QT interval. And like I was saying, predisposes them to torsades. That's what that TDP means, torsades. Torsades de point. So it can be acquired or it can be inherited, like what we were saying. What causes it? All of these things.
I call it digitalis.
Look, ditch, boom. You're going to see that most commonly, you're going to see that tricyclic antidepressant overdose, but maybe not anymore because you don't see TCs as often as we used to. Trauma. So trauma patients are hard. As you guys will find out, I've got some really cool trauma cases. Car accident, unresponsive patient, low blood pressure, and you have to like fix 5 things before you can fix that blood pressure, right? They get smashed into the steering wheel, they've got punctured lungs and a tension pneumothorax. Well, that's going to cause hypertension. You fix that, still hypotensive. Like, well, their rhythm's bad. They've got, VTAC or VFib, and you shock them, and you try to get that fixed. Okay, that's fixed. They're still hypotensive. Well, they got starting on the windshield, spine got injured, and it's a neurogenic shock as well as a cardiogenic shock. You got to give them pressors. Well, now the blood pressure is finally a little bit better. Trauma patients suck because you do one thing and it might not fix the patient. You're like, oh crap, was that not it? And oftentimes it's just, well, that's just not all, right? You're missing something. All right. So VTAC signs and symptoms vary. Sometimes you can have patients in VTAC, they just feel near syncopal. They passed out. And that could be because of a run of VTAC that spontaneously fixed itself. So VTAC, obviously anything that's causing low perfusion, it's going to cause altered mental state, shock, chest pain, hypertension, shortness of breath. You get back up into the lungs, the rails. Monomorphic VTAC, stable, but the patient is symptomatic. They can feel it, but they're still getting perfusion. Oftentimes it's monomorphic. Can be a little bit slower. They can also have unstable patients because they can get up to 250, right? So CPR and defibrillation on a pulseless patient in VTAC. In all cases of VTAC, you want to figure out what's causing it. What's a common medication I'm given ACLS for patients with VTAC? Amio. And why do you think that is? You guys know what amio? You guys had amio yet on farm? So what is amio? What kind of medication is it? Class 3 antiarrhythmic. So it has multiple actions, right? It affects calcium channel blocker. It affects the sodium, potassium pump. It affects, multiple different, those are the two big ones, but it affects multiple different aspects, and that's why it's effective with VTAC and VFib, because it's really resetting. All right, polymorphic VTAC, same thing, right? You can have stable, unlikely that you're going to have polymorphic VTAC that's stable, but you can. Unstable, CPR, defibrillation. In all cases, find out what's causing it. So if you have an SVT with an intraventricular conduction delay, like what? Aberrancy? SVT with aberrancy? May be difficult to distinguish from VTAC because it's wide. Right? You've got a tachycardic wide complex, automatically you think VTAC. Well, it's a possibility it could be SVT with aberrancy. If you're unsure, do you want to treat it like SVT or treat it like VTAC? Yeah, I mean, if it's truly stable VTAC, that means that it's a little bit slower. And hopefully you might be able to identify. But yeah, certainly if they're stable, you could try. But
if you gave them adenosine and you killed that AV node, would you maybe put them into
well, they're already not getting any conduction from the AV node with VTAC. The point is if you've got a patient with VTAC and you don't know if it's SVT, well, the SVT with aberrancies can be rare. Treat it like VTAC. The VTAC is the one that's dangerous. Yeah. You got stable, wide complex tachycardia. Which kind of electricity are you giving? Synchronized, which is that's what you meant. Yeah. Synchronized. So you're not just defibrillating the patient, you're doing a synchronized shock. Well, a synchronized shock is going to treat either stable VTAC or SVT, right?
Can you explain a little bit of synchronized shock?
Synchronized shock, meaning synchronized from the machine, is when the machine is detecting each QRS and it's giving the electricity at a very certain point during the QRS complex. So it's not just randomly firing like a defibrillation and just defibrillation is electricity kind of everywhere to just completely reset the heart, where synchronized is you're resetting at a very specific place in that QRS complex.
So does it slowly titrate the rate down?
A synchronized shock won't, or at least shouldn't, has a much lower likelihood of putting the patient into VFib.
Yeah, so my understanding was the ROT put on
talking about?
Mhm.
QRS happens on the T wave. That's when you put them in a VFib or VSAC. That's what you're trying to avoid.
Right.
So the machine is not going to get to them at that time. It's going to get to them another time and it won't cause them like that. With defibrillation, you don't know. Push the button. And you push the button at that exact moment. Put them in.
Right.
So you're trying to avoid that.
Now, unstable VTAC, you're just defibrillating. That means it's so fast that you're not going to be able to synchronize, likely. All right, VFib.
You throw them in the VFib, you just shock them again.
That's right. So VFib is chaotic, like AFib, but there's no QRS, right? No organized depolarization of the ventricles. You got quivering of the myocardium, just kind of doing this thing. And you don't have any kind of effective contraction. That's VFib. No discernible PQRS complex or QRS complex or really anything. Fine VFib, it can be confused with what? Asystole. Yep. Or can just be on a really obese patient. You're not, the machine's not sensing very good electrical conduction. What's that?
Even though that's so close to asystole, is that still shock?
You could try it. You could say, I don't know, fine VFib or asystole. Well, if it's asystole, we're not going to do anything except for maybe continue CPR, and this patient's probably not coming back. If it's fine VFib, we're going to shock him and try to get him back. So yeah, I would try it. If you think it might be fine VFib, I'd shock him.
In the field, I've seen monitored, you can't really tell if the fine VFib or systole. You're sitting there and I've seen people say, well, is that systole? Is that VFib?
Right.
What's the harm to shock?
No harm.
No harm, great.
Asystole is what? Asystole is dead, right?
Right.
There's no harm in shocking a dead person. Now, if you're trying to fool yourself into thinking that asystole is fine VFib 10 times, I'd probably call it quits. Right?
Right. Just shock.
Because there's a lot of things that those pads and the electrical system are picking up. So very rarely are you going to get a straight line asystole. It's always going to have, little things, deflections.
A lot of guys like to look at the monitor, and I've noticed that, just with ECGs in general, when you print out what you see on the monitor, it's a different thing.
Yeah.
And so,
That's true too.
For me, I'd like to
Print it out and take a look at it.
Take a look at it before I decide, yeah, that's it.
Sure. That is very true. Oftentimes the monitor and what you see on the paper can be different. All right. What causes it? Well, a whole bunch of stuff. All the same stuff.
What's that, lady?
Yeah, but then what could you like?
More racist. The difference between VFib and PEA, they're pretty close to each other, right? Those labels.
No, I'm asking about asystole and PEA. I don't know.
The treatment is similar, meaning that you don't shock either,
Right.
but conceptually they're different. Asystole, there's no conduction. PEA, there's conduction without contraction, or enough contraction.
Okay, so could it look like fine VFib?
What? Which one?
Could PEA look like fine
No.
VFib?
No, he and
You're still gonna have pulse.
PEA, you're going to see QRS complexes.
Okay.
They do racist incense. This is the guy's table.
How did, I'm not gonna play your game.
I'm judging.
Interesting. That's exactly what a racist would say.
We were all gonna go to your church this week.
All right. VFib, CPR until you've got a defibrillator ready and charged, right? And then do you wait for the cycle for the CPR? Nope. As soon as it's ready, pause, check the rhythm, and shock if you can. You defibrillate as soon as the defibrillator arrives, and then right after the shock, do you wait to find out?
No.
Continue CPR. You guys are so good with your BLS. Gosh. Defibrillation. So indications for defibrillation, pulseless VTAC, ventricular, and VFib, right? Purpose of defibrillation is to produce momentary asystole, to stun the heart so that it can reset. The shock, you give enough electricity to the heart all at once, the heart completely depolarizes. So then it goes into the state of nothing for a little bit, right? Until it can reset. So that you're not getting these random little depolarizations everywhere with this fibrillating state. Completely kind of zeroes everything out. All right, defibrillation procedure. You guys know all of this. Step 1, verify that it's indicated. Step 2 procedure, so you hook them up to the pads, you remove the clothing. If they got a really hairy chest, what do? Shave them, or hope you have 2 sets of pads. Put the first pad on and then rip them off and get all the hair off, and then put the second set of pads on after you've ripped off all the hair. All right? You want to avoid placing those pads on real bony extremities. Obviously, you're going to put them on the sides. Their rib cage is there. The optimal patient is somebody who's not anorexic but not obese. It's kind of that middle ground where they've got some tissue there, so you're not zapping them right into the bone, but they don't have too much tissue that it's not getting to the heart or going around the heart. Does that make sense? Okay, so you hook them up to the monitor, and which buttons are you pushing? You are not pushing all of them.
You turn it on, and you push analyze. We can push charge.
So you're putting the pads on, and you're checking the rhythm, right, to see if it's something appropriate to shock, right? Either pulseless VTAC or the VFib. You're charging the defibrillator with a button that says charge, which is nice, right? You guys are familiar with this monitor? Oh, you guys don't use this one, huh? So we train with this one, but you guys don't use it? Well, that sucks.
They're more or less the same.
Either way, does your monitor or machine have a charge button? Okay, it will say charge on it. So you've verified a correct rhythm. You charge at what joules? 200 joules with what kind of monitor? That's for AFib. So defibrillate at 200 joules, you can go up to 360, but for a biphasic defibrillator, more than 200 joules is really kind of the same thing. You're not getting a whole lot of more benefit from it.
What's biphasic?
So there's monophasic and biphasic defibrillators. Most of your defibrillators are going to be biphasic. Basically, what it means is that you're not requiring as many joules to get the same effect. So you're not, burning patients. It's handy, especially with pacing patients, because you're not requiring a whole lot of amplitude. Because you can imagine if you're transcutaneously pacing somebody for a long period of time, that affects their skin, it affects their tissue, it affects a lot of stuff, right? So biphasic is able to, it requires less energy. All right, clear, and you can hit the shock button once everybody is clear, right?
So are we going to talk about between the range of 200 and 360? What should we be starting at?
Generally, I mean, for biphasic, you start it at 200. You wouldn't get any fault in shocking somebody at 300 or 360, because that is done I should say traditionally.
So our machines start at the default of 360.
For defibrillation,
Yeah, so if you hit charge,
it's at 360.
It automatically goes to 360.
Then you can shock them at.
That's just what they set them at. When they do
If
it
you're
now,
doing
you can
keys,
spin
you
the
want
dial.
to go
Yeah,
lower.
but you have, so,
Yeah, PEDS is specific shock for how big the patient is, and it'll say on the bracelet. Yeah. It'll say how many
I actually
joules.
just had that with 13 with Kyle, that's how we did that. And we actually had they had a look it up and find, I think it was something like 70 joules or something like that. Yeah, it was horrible. Yeah.
My house is right across the way. I watched you guys.
It was horrible.
They didn't even come up. You just saw it on post one.
These are the
Defibrilation. I've been seeing a lot lately about putting the pads more posterior than on the side to get a better.
We talked about that, I think, last time when you weren't here as well, where you really want to put the pads in a position where you're squeezing the heart, right? And especially on an obese patient, right shoulder and side, you're missing the heart, right? It's going through tissue and not going through the heart. So front to back is what I always do in the hospital.
You still want to do like up on the right shoulder and then just more posterior back.
Yeah, you could do that as long as you're squeezing the heart and you're making sure that you're squeezing the heart.
Oh no, so the counter argument to that though is like they tell you to put them that way because they want it to go with the electricity to go towards the standard axis of the heart.
Okay,
which is
right,
like,
towards the meaning
versus-
you mean shocking from one pad to the other,
so
atrium
axis-
to ventricle.
Yeah, normal axis deviation is more typically this way, which is why it pads in front and side versus front to back, which is
Right.
typical.
But that is effective with synchronized or with pacing a patient. But if you're defibrillating a patient, does it matter if you're going in the access?
No,
Because you're just turning everything off, right? You're just depolarizing the whole thing. All right. So, it's going to be patient specific, and it's good to know the reasons why we put the pads in the certain places. But if you've got a super obese patient and you're going to defibrillate, don't worry about the access. Worry about getting the heart and not frying a bunch of fat tissue. If you've got a PEDS patient that you're doing a synchronized shock, then yeah. If you're in that PEDS patient, if you're going to be getting the heart in between those two pads and you can line them up with the axis, perfect.
Actually, the PEDS
Synchronized
pads
shock.
tell you to go
Front and back?
Front and back, yeah. And you don't go front and side on the PEDS.
Well, and again, I think it depends on what you're doing.
Some kids are so small, and you probably can do the side.
Yeah, you can do the side one with it.
I did it in the whole chest.
Yeah.
Right.
This is what
So for the most part, in any kind of ACLS protocol, especially for BLS, they simplify it as much as they can so that people are doing the most optimal thing that in the easiest manner. Does that make sense? So they teach it a certain way so that those BLS providers are just going to do it and know how to do it, and they have that the pictures on the machine so that it's easy. so people aren't sitting there going, oh, wait, what should we do here? But you guys have higher education. This is what this paramedic class is for, and you can think about those kind of things so that you can get the optimal shock, right? As they're putting on the pads, you can be like, oh, what's going to be a better way? If it's going to take too much time and you're like, oh, shoot, what did Dr. Raby say? And just throw them on the way that you know how to throw them on. And if it's wrong, I'll tell you it's wrong when you get to the hospital. What's that?
Placement of that pad, you want to anterior and scapula lateral to the spine.
Mm-hmm. You don't want to bypass the heart from the backside either.
Yeah.
Right? So you just got to make sure that your pads, from what you're seeing, are squeezing the heart. Right? Okay. So you guys have seen those. I mean, you guys have seen those super obese patients. They're laying down there and they've got so much excess tissue. They throw a pad on, throw a pad here, and you're like, well, the heart's like a foot deeper than that. And those pads are just not going to do it, right? Sometimes the patient's too fat and the machine can't shock them anyway. There's too much tissue there. So you never get an effective defibrillation. But
Will it, in that case, Dr. Reed, will it just read like no shock advised? Right? If that patient is so obese and
well, it'll read no shock advised if they're in a rhythm that shouldn't be shocked. Sometimes it'll still read the rhythm.
Yeah.
The shock just won't be effective.
Okay, so we'll read the rhythm to shock them and it won't be effective. Okay.
Right. And you're like you shock them, they do their thing, CPR, and it just doesn't change. The shock's not effective.
What do you think of, it's like synchronized biphasic defibrillation? They're going in Europe or something like that, where you've got two different defibrillators at the same time, front to back and then side to side.
So they're really trying to ensure they got a squeeze of the heart.
Something like that.
It's one for refractory beef.
I don't know.
They try to beef it like multiple times now.
I don't know. I've never used or seen those machines. So this is classic asystole, right? This does not look like fine VFib, although you're going to see little teeny spikes. What do you think those little teeny spikes are? Just whatever?
Random little blips of,
Yeah. You might see P waves. And it's still asystole. Yep. Ventricles aren't firing. There's no QRS, no pulse. Looks like asystole. Sinoatrial node's still pumping away. Too much time, and that sinoatrial node's going to die, and that's going to be gone too. But I mean, it really could be any of them. Or it could be just a massive MI where it killed off the whole ventricular conduction system as well as the musculature, but the atrium still. And it might be just that the atrium, you've got conduction at the SA node, but it's not creating any kind of pump. I'm just saying that certain times it's still asystole.
Yeah.
All right. Because there'll be some medics that will see that and call it PEA. Now, is the treatment the same anyway? Yeah, probably. That code just might last a little bit longer. All right. So causes are the same as PEA. as we talked about before with like adenosine, with, you know, defibrillation, whatever, you can have pauses of asystole while you're trying to reset everything, and then the sinoatrial will kick in again. Treatment of asystole, CPR, confirm the rhythm in 2 leads, meaning that's when you don't want to just trust your monitor. You want to print it out so you can see more than 1 lead. And then, of course, all the ACLS type actions. Put in the IV, you're giving medications, put in an airway. Bad form to bring a code patient, asystole, or whoever to the hospital without a definitive airway, which can certainly be an iGel, but it needs to be something, right? Questions?
So Dr. Rady,
Yep.
I kind of ran into that situation the other day. Why, we're not supposed, I've always thought we're not supposed to transport dead people, we don't transport asystole, but why would I transport asystole with a definitive airway? What makes the flipping difference if they're both asystole? What's the
Well, I guess
process?
in that aspect, if you never got anything back, you know, you didn't get ROSC and it terminates at the home or wherever, when the coroner comes and gets them or whatever, I mean, that'll be on the record from the autopsy that this patient did not have a definitive airway. And that might come back on you. That's what I'm saying. From a legal standpoint, anytime you have these kind of patients, they need to have an airway.
Okay.
I mean, from a clinical standpoint, absolutely, they should be having an airway anyway.
Okay. Yeah.
Because you need to have a definitive airway when you're doing this kind of procedure, right? But I'm saying that if at the end, you know, I don't want you to intubate or put an iGel on somebody that's already done and you've called it and like, oh crap, I didn't put a definitive airway. I'm saying that a patient coding or a patient that has VTAC, VFib, asystole, PEA, somebody that you're running a code on needs a definitive airway, right? CPR is more important, but it'll come back on you if they don't have a definitive airway.
What you're using it over for PEA.
Right.
Hypoxic and you have acidosis.
Yeah.
You can't fix that without airway.
Yep. Any other questions? That's a good question. No.
You're stunned silence.
Doug wants to come in and do a review.
That's that bad.
All the shit.
Was the test really that bad?
Yeah, it was not.
Give me an example of something that.
What surface of the heart is 1, 2, and 3 EVR?
Wait, say what? Say it again.
What surface of the heart does it have?
What surfaces of the heart? Well, it depends. Each lead does a different surface of the heart. Let's see.
Questions.
Yeah.
Describe which surface of the heart, lead 1, 2, 3, and which electrodes were positive.
The 1, 2, and 3 would be the right side of the heart and inferior. Which other leads? Was it asking?
One is left side of the heart, right? One's left side.
ABL means the left side.
Gary did that. That's kind of mean.
Hey, could you kind of go over anterior, inferior on the heart as it sits in the chest?
Oh, no, I guess.
If we're talking inferior, we're just talking down by the apex.
All right.
Yeah.
So if that's your heart, your inferior is going to be right side and underneath. That's inferior. Septal
Which would be lead 2, right?
is right there.
And septal gonna be lead
Right.
2.
And then you've got, left side of the heart, or I should say anterior and left is going to be kind of the rest of it. But honestly, surfaces of the heart don't
It's not
really get,
surface of angles, right?
it doesn't get super important until we get into 12 leads. That was a question.
Yeah, was a question.
Surfaces of the
Yeah,
heart.
it's gotta be more than that, probably better.
Right. Well, and sometimes Gary pulls out random stuff from the book that I told you guys he loves those boxes and he loves the side tables and right? I'll talk to Doug about it. I'll stay here for the review and we'll see. What's that?
I said that Gary also did say that everything would be going to test.
Yeah.
Never said that.
All right, I'll go get Doug.
What's your opinion on
It's hot in here.
precordial pumps? I know they've kind of been phased out.